Well, I put this talk together actually for a conference out here in California, the Western Foot and Ankle Conference, and it was very well received. Um, it really, the foundation for it is the fact that when I was in school, and I think still today, there's never really been a comprehensive teaching module put together for foot drop. The students are given background in neurology classes about the causes of foot drop, but really to put it all together in one lecture, the cause, the effect, the biomechanical effects, and then treatment options is something I haven't really seen put together in one concise lecture. So this is what I'm doing for you this evening, and I hope you find it valuable. It's all focused on clinical practice, and hopefully some of the stuff I'll share with you can put to work tomorrow. I myself commonly use the word drop foot, but in the medical literature, the term is foot drop, and I will probably fall back on my old habits and refer to it as drop foot, but from here on, it's foot drop, and it's just basically a very simple description of a gait abnormality characterized by an inability to dorsiflex, not just the foot, but the toes and the ankle. Keep in mind, foot drop is not a disease. It's just a symptom of an underlying condition. Um, and that's what we're going to talk about tonight is what conditions cause foot drop. So one of the underlying themes I'm going to bring out here is the fact that uh, we have patients in our practice who have foot drop and we don't even know it, and they don't know it. This is an example of a patient in my practice who I conducted a cursory visual gait observation on, and she has a very mild foot drop, which for some of you watching her walk, you may not even know which side it's on. And we're going to come back to her and talk about what caused her foot drop and how we treated it. So just to review, in gait, we need to be able to pull the foot into dorsiflexion during swing phase such that at mid-swing, we need the foot at least a neutral position, if not slightly dorsiflexed, so that the toes can clear the ground. And then just as important, we need to maintain the foot in a dorsiflex position at touchdown because we need to start a series of events beginning with heel strike and mid stance and push off, which are unique features of the human walking gait cycle not seen in other primates. No other primate heel strikes like a human does. Chimpanzees and apes, for example, strike on their forefoot and then they land on the heel. Those muscles that are responsible for maintaining dorsiflexion, as we all know, are the tibialis anterior, extensor digitorum longus, and the extensor hallucis longus, and they are all innervated by the deep peroneal nerve. Commonly associated with foot drop is loss of innervation of the superficial peroneal nerve, which innervates the peroneus longus and brevis, and that's why commonly foot drop is also accompanied by a varus posture of the foot during swing phase and during the stance portion of the walking gait cycle. So most of us were trained and were reviewed the multiple levels of our nervous system that can lead to foot drop. And we're going to do a brief overview and try to come up with some clinical pearls for you to make this all make sense. So we really, if we work backwards to the very beginning, we're really looking at where the deep peroneal nerve originates from, because it's loss of the deep peroneal nerve innervating those muscles that causes foot drop. So we'll start at the top with the cerebral motor cortex and its descending fibers. We're then going to move into the lumbar spine nerve root, the lumbosacral plexus, and then the ultimate formation of the sciatic nerve. So starting in the brain, a very common cause of foot drop is a stroke. Just a couple interesting statistics, about 800,000 people in the United States have a stroke every year. And of these, the vast majority are first-time strokes. About 1 in 4 are a second time or third time stroke. And the majority of strokes, the vast majority, almost 90% of strokes, are ischemic rather than hemorrhagic. So just some interesting facts there. And as we know, many times the ischemic stroke affects the motor cortex of the brain, specifically two key areas, the premotor area or the supplementary motor area, which then compromises motor activation of the nerves that ultimately form the common peroneal nerve. So some keys with patients who have foot drop, who have suffered a stroke, they walk in a different way than those, for example, who have a sciatic nerve injury or injuries farther down the chain. So some key factors that we see in the hemiplegic stroke patient are flexion of the arm, internal rotation of the leg without really a swing phase. Often we will see circumduction of the affected limb, and this is really due to not just foot drop, but proximal leg weakness, as well as hypertonia, which is really a key feature of the clinical findings after a stroke. So we not only see weakness, but we see hypertonia in these patients. And that's a key differentiating feature from, for example, a common peroneal nerve injury farther down. The clinical findings of clonus, Babinski, hyperreflexia, when you do your lower extremity exam, should be a clear indicator that this patient may have suffered a stroke and didn't even know it. And certainly the evidence of clonus, Babinski, hyperreflexia indicate a upper motor neuron lesion, not a lower motor neuron. So this picture of the left arm being flexed, the foot drop, and the circumduction of the limb are all hallmark features of a stroke patient. And indeed, we see the exact same reproduction in this video of a patient of mine who's got the spasticity of the posterior musculature, the foot drop, and more importantly, the circumduction of the leg in swing phase. Circumduction. So this is just a post-treatment with a very simple Richie brace intervention. This is our restricted hinge brace, which I'll go over in more detail later. And what we see is control of the foot drop, not necessarily control of hip circumduction and the spasticity of the upper extremity, because an AFO will not control that. So if we move down to the lumbar spine and the lumbosacral plexus, innervating the sciatic nerve, we see a different clinical presentation when these nerve roots are affected. They ultimately form the sciatic nerve, which branches distally into the tibial nerve, and then for our interest, the common peroneal nerve. So it's well known and documented that acute foot drop is almost always due to L5 radiculopathy. In other words, a patient who goes to bed healthy, wakes up in the morning with a foot drop, your number one differential should be a herniated lumbar disc. This is not the most common cause of foot drop, but it's the most common cause of acute onset of foot drop. And lumbar disc herniation is not as common as stroke, but it is a common cause of foot drop. And usually when a patient has a lumbar disc herniation, at least half the time, they develop foot drop or dorsiflexion weakness. What's interesting here is in a lumbar disc herniation, eversion is generally left intact. The peroneus longus and brevis still maintain innervation from the sacral nerve roots to the sciatic nerve. So that's a good way to differentiate perhaps a stroke patient or a common peroneal nerve entrapment, which will include the superficial peroneal nerve. So when we see a lumbar disc herniation, we see, of course, dorsiflexion weakness, but here we see maintenance of eversion And finally, the most important is the patients have pain. They have pain and paresthesia over the L4, L5 dermatome. So when we see foot drop accompanied by pain over a dermatome, we really want to focus on the possibility they've suffered a lumbar disc herniation. We will also see hip abduction weakness on physical exam, but I think here pain is that real key identifier. Farther down, we can see or this is not farther down, this is an aside. We will see foot drop in patients who undergo spinal surgery for a ruptured or protruding herniated disc. Now, it's a misconception that that surgery has a high risk of causing foot drop. The literature shows that the risk of it varies anywhere from less than 1% to at the most 7%. But the patients who have foot drop after lumbar disc surgery are patients who already had a foot drop before the surgery. And if they've already developed foot drop, which often prompts them to have the surgery, about 30% of them are going to continue to have foot drop even after a successful lumbar spine decompression or other surgical procedure. So these poor patients, if they're getting radiculopathy, an early sign of foot drop, they really should be encouraged to consider surgery, because if they let this foot drop persist, even having lumbar spine surgery, they've got a 30% chance of a permanent foot drop afterward. Finally, we see iatrogenic causes of foot drop after total knee replacement, after total hip replacement. These total hip surgeries sometimes are likely to affect the peroneal branch of the sciatic nerve and not the tibial branch. The risk factors are low, but they're real. And I think we've all seen patients in our practice who go in for elective hip surgery and wake up with a foot drop, which often is not reversible. This is a patient of mine who had a lumbar nerve root iatrogenic injury after a lumbar laminectomy that was permanent. In this case, it affected both the peroneal and the tibial nerve, leaving the unique combination of adult-acquired flat foot with foot drop. So this is a real unfortunate iatrogenic injury and a challenge, because it's not only a foot drop, but it's a severe adult-acquired flat foot. Combination tibial nerve and peroneal nerve. However, very successfully treated with our Richie brace with arch suspender. That's a fixed position ankle brace that holds the foot at 90 degrees, and it has an additional varus control mechanism with a lifting strap. And you can see this brace restores heel strike, solves the foot drop, and restores an almost relatively normal gait pattern. So these interventions can in fact be very rewarding. But the most common cause of foot drop itself, not acute foot drop, but subclinical foot drop or chronic onset, slow insidious onset of foot drop, is injuries at the fibular head that affect the common peroneal nerve. So compared to radiculopathy, common peroneal nerve entrapment or injury is almost twice as common. Common radiculopathy and polyneuropathy, such as Charcot-Marie tooth, pale in comparison to injuries at the fibular head, which is interesting because these injuries are in many cases preventable, if not treatable. So the common peroneal nerve, as it courses over the neck of the fibula, is uniquely situated to undergo compression neuropathy or traction neuropathy simply because of its anatomic location. The common peroneal nerve passes through a very tight corridor, the floor of which is the fibula, and the roof of which is a myofascial envelope formed by the insertion of the short head of the biceps femoris as well as the lateral head of the gastrocnemius. So there's not a lot of room in here, and there's a very rigid, unyielding bone floor formed by the neck of the fibula. So we can see contribution of this biceps femoris overlying the superficial or the deep peroneal nerve, as well as the gastrocnemius and the fascia that attaches these muscles to the fibula. So this common peroneal nerve, when it is entrapped or damaged, will affect both the ankle dorsiflexors as well as the peroneals. So when we see simultaneous effect of both the dorsiflexors and peroneals, we pretty much know this is not just deep peroneal nerve, but it's common peroneal nerve. So the common peroneal nerve can be damaged through slow insidious trauma, which I'm about to show you, but it can also be damaged with acute trauma, particularly in athletic competition with traumatic knee dislocation. So we will see high-level, high-performing athletes suffer severe injury to the common peroneal nerve, along with traumatic knee dislocation, which the after effects of the common peroneal nerve injury far outweigh the ligamentous injury. One of the more famous stories took place in the Fiesta Bowl about 6 years ago. Notre Dame was playing Ohio State, and this fellow here, Jalon Smith, was the winner of the Butkus Award that year as the nation's best linebacker. And he suffered a non-contact hyperextension injury of his left knee during this game with a severe traumatic dislocation of the knee and a severe traction injury to the common peroneal nerve, leading to a foot drop. He underwent several surgical procedures which stabilized the knee, but the common peroneal nerve was left to heal on its own. He went from a projected #2 draft pick to a 6th round draft pick that year. And he was drafted by the Dallas Cowboys, and the athletic trainer there fitted him for a Richie brace, a dynamic assist brace, to allow him to continue practicing and regaining his fitness while hopefully recovering from the common peroneal nerve injury. This was in 2017. So there's a picture of him wearing the dynamic assist brace. This brace was chosen because it could fit into his football cleat and because it allowed full unrestricted ankle joint range of motion while giving a dynamic dorsiflexion assist to his ankle during swing phase. As luck would have it, the starting linebacker for the Cowboys that year was injured during preseason, and Jalon Smith became a starter for the Dallas Cowboys despite a complete foot drop condition in place. He's wearing his Richie dynamic assist brace here, covered with tape, and he started and played in all of the games that 2017 season. And happily, his common peroneal nerve recovered in about 12 months, and he was able to discard his Richie brace. And the next year, he became an All-Pro and signed an extended 7-year contract worth over $30 million. So pretty nice outcome for Jalon Smith and everybody involved. A less famous story, but a common story. This is a patient of mine who was struck by a car. He's 28 years old. He suffered a traumatic knee dislocation. He had surgery. He wears a knee brace still because the knee is still unstable, but he has a common peroneal nerve injury with the altogether combination of foot drop and varus rotation of the ankle due to loss of the superficial and deep peroneal nerve. So flaccid foot drop, varus instability, wears a knee brace because the knee is still recovering. He's a good candidate for the Richie dynamic assist brace. And you can see it restores heel strike and pretty well manages the varus instability during swing phase. And the brace does not interfere with his knee brace because it's a very low profile brace. And the patient is very happy. So besides direct trauma, as I just showed you, we can see other insidious onset of compression peroneal neuropathy, as we're all aware, putting on an improper plaster cast or brace, improper positioning of the patient during anesthesia, coma, or sleep. Anything that puts prolonged pressure on the common peroneal nerve can cause neuropathy. Don't forget that tumors in the common peroneal nerve, as well as tumors around the knee joint. And this one here, prolonged squatting and kneeling, are known to cause low-grade but persistent trauma to the common peroneal nerve and acquired foot drop. So this is a well-known habitual sitting cross-legged, can eventually lead to foot drop due to the compression neuropathy. Habitual kneeling in a hyperflexed position is thought to put traction on the biceps femoris. And this actually has a name. It's called strawberry picker palsy, where the common peroneal nerve is compressed between the biceps femoris tendon and the lateral head of the gastroc, either in prolonged squatting or in this case, prolonged kneeling. So these relatively benign postural habits can cause what sometimes leads to permanent nerve damage and foot drop. Another palsy called slimmer palsy we're seeing now with the onset of weight loss medications, Wegovy and et cetera, have been known and been reported in the literature to cause foot drop with a loss of the protective peroneal adipose tissue around the common peroneal nerve, combined with probably postural aggravation, whether it's prolonged cross-leg sitting or squatting or bending. So it's an interesting thing to keep in mind with patients who undergo significant weight loss. We're starting to see reports of this. We also see peroneal neuropathy associated with diabetes. Keep in mind, diabetes can cause mononeuropathy. And in almost all these cases, it sets up a syndrome which we call subclinical peroneal neuropathy. These are patients walking into your office who have subtle foot drop and they've never been diagnosed. A recent article in our journal of the American Podiatric Medical Association, this was a clinic in the UK that diagnosed subclinical foot drop in patients who never had been diagnosed. And it was caused by abnormal posturing and sitting, which simple elimination of those habits allowed the common peroneal nerve to recover. And without any other treatment, including no surgery, the foot drop condition completely resolved. If the condition is not resolving with removal of those postural aggravations, surgical intervention to decompress the common peroneal nerve has a pretty high success rate. The literature reports very favorable results with decompression of the common peroneal nerve, which involves releasing the fascia of the medial head of the gastroc, the lateral head of the gastroc, as well as the biceps femoris tendon and fascia around the nerve. So we see good reports of positive results as long as the surgery is performed within 3 to 4 months after onset of symptoms. The outcome are not as favorable if we wait 12 months or longer. So if you have a patient who comes in and you're suspicious that they may have dorsiflexion weakness leading to possible subclinical foot drop, there's some real simple clinical tests you can perform as an indicator, besides just doing manual muscle testing, which often is not adequate in reproducing the weakness. So I'm going to go through these clinical tests briefly. Of course, we perform gait analysis and we look for foot drop, we look for loss of heel strike, and we listen for a foot slap. We will then ask the patient to walk up and down the clinic on their heels, the so-called heel walk. We then do a test called heel rockers, which I'll show you, and if possible, have the patient do repetitive stair stepping. So this is a patient who has a very subtle foot drop on the left side. And the reason we can detect it is she doesn't heel strike. She tends to midfoot and forefoot strike, whereas on her right side, she clearly heel strikes. So just a very subtle difference there in their heel strike pattern, which may not be initially apparent. If we look even closer, and which we really should, look up higher and look at her asymmetrical arm swing, because indeed there's a difference as she gets closer here in the arm swing of the right versus the left. And indeed, this patient has had a stroke leading to this mild foot drop. This is a really good test to do to pick up weakness of the dorsiflexors, and it simply asks the patient to walk on their heels or keep their toes off the ground while they walk up and down the clinic. And often you will see they are unable to do it on the affected side versus the unaffected. Ask the patient to repetitively step up and down on the stairs one at a time, and as the weak dorsiflexors fatigue, they will have an inability to clear the ground and step up onto the step onto the affected side. One of my favorites and the easiest of all to do is ask the patient to lean against the wall with their feet approximately 12 to 24 inches away from the wall. And you ask them to rock up on their heels or ask them to lift their toes off the ground, back and forth. Lift your toes off the ground and back. Rock up on your heels. And you will see that the weak side will be unable to do so compared to the strong side. So we compare right to left. You have them do this repetitively because they may be able to do it for the first 10 seconds, but after about 30 seconds, they will noticeably fatigue and be unable to pull the foot off the ground. Great test to really pick up these subclinical cases of foot drop. Of course, you should do a sensory exam. In the case of the deep peroneal nerve, when there is entrapment, there'll be a clear area of paresthesia or anesthesia in the area innervated by the deep peroneal nerve, or in some cases, both the deep and superficial peroneal nerve. So we definitely do sensory exam testing, definitely do your reflexes, because if we see hyperreflexia and clonus, it's a clear indication the patient has an upper motor neuron disease, not a lower motor neuron. Now we're going to move on to polyneuropathy as a cause of foot drop. These are diseases that affect not just the common peroneal nerve, but other nerves of both the upper and lower extremity. And these patients commonly present to podiatric physicians for help, whether it's help with digital deformity, help with shoe fitting, help with just routine foot care. We see these patients. We should understand more about their disease and in many cases use ankle-foot orthoses to intervene and help them. As we know, multiple sclerosis is a disease that seems to be increasing in frequency. It has specific gait patterns that show up that should be a hallmark when you perform gait analysis on your patients. Specifically, we see decreased stride length. We see them in prolonged double limb support because they're unsteady. This is a central nervous system disorder. This is not a peripheral nerve disorder. Of course, we see foot drop in these patients, but it's primarily due to reduced ankle joint dorsiflexion. Yes, it might be due somewhat to muscle weakness, but it's really almost always due to contracture of the posterior ankle musculature. Reduced push-off. They have decreased ankle plantar flexion and decreased ankle dorsiflexion. So it's really a unique gait pattern that we don't see. It's uniquely different than Parkinson's, and it's uniquely different than stroke patients. So here's just a video of, well, it's supposed to be a video of what it looks like. Thought I had it. Maybe not. Sorry about that. We're going to move on to Charcot-Marie tooth. We all see patients with this disorder. Just a reminder that most of these patients exhibit symptoms in the first or second decade of life, insidious onset of weakness, beginning with the lower extremities, but later involving the upper extremities. But we all recognize the progressive acquired deformity, mainly cavus deformity and digital deformities. Now with genetic testing, we've really paved the way and come up with much better ways to not only diagnose Charcot-Marie tooth, but to classify it into 3 different categories with simple genetic testing. For our purposes, we see this characteristic anterior cavus. This is all due to muscle imbalance. It leads to varus deformity, cavus deformity, and claw-toe contractures. These patients do develop foot drop due to anterior lower leg muscle weakness, as well as peroneal nerve and muscle weakness. It's a progressive disease, and it's unpredictable depending on which category the patients are in. But in most cases, the patients are managed with ankle-foot orthoses to prevent foot drop and progressive contracture of the posterior leg musculature. Depending on the severity of the disease, different types of AFOs are indicated. This is a patient of mine. She's a registered nurse at our hospital who has foot drop with Charcot-Marie tooth, but she doesn't have severe contracture of the calf. So she's an excellent candidate for our dynamic assist brace. Here she is with the typical, very flaccid foot drop and significant varus instability because the peroneal loss of function is almost as prominent as the lack of dorsiflexion. So this combined varus instability is a challenge for the patient and for the treating physician in terms of using AFO therapy, not just the uniplane foot drop, but the varus instability. So we used our Richie dynamic assist brace, which nicely controls the varus instability. A little bit of in-toeing left here. The patient is delighted because she's heel striking, she's not tripping and falling, and she's wearing very comfortable ankle-foot orthoses that fit nicely into her lace-up athletic shoes and allow full mobility. So moving into treatment, we're going to go through the 4 tiers and options, and I'll go over each of these to some detail. All patients with foot drop eventually need to go through rehabilitation. Stroke patients need to go through rehabilitation because many of them restore some neural activity in the brain and need to rely on a skilled rehabilitation specialist to do that, starting with the brain and moving down to the ankle. Even whether it's a common peroneal nerve entrapment, whether it's an iatrogenic injury after total knee replacement, all of these patients benefit from stretching, strengthening, balance training, and gait training because a lot of them get better. A lot of them progress to the point where sometimes they can even abandon their ankle-foot orthosis and resume a normal, healthy gait. So we are obligated to put them into a focused, comprehensive rehabilitation program early on, regardless of the etiology. An interesting option for patients that many physicians are not aware of is functional electric stimulation. This really came about almost 30 years ago with the onset of an external stimulator placed over the common peroneal nerve, which activates or stimulates that nerve the minute the heel comes off the ground and initiates a firing of the common peroneal nerve for stimulation of the ankle joint dorsiflexors. And it basically takes over that essential function of firing the common peroneal nerve during the swing phase of gait. In the early days, it was brought upon by a communicator in the shoe that the minute the heel comes off the ground, it communicates either through a wire or through today through Bluetooth type technology to the stimulator, and it tells the nerve, it tells the electrical device, okay, the heel's off the ground, stimulate the common peroneal nerve and activate these dorsiflexors. So here's what one of these devices looks like. It's placed over the common peroneal nerve, and its primary purpose is to stimulate dorsiflexion during swing phase. There's been a lot of studies done on it, and the devices are remarkably effective. And patients tolerate them, and they prefer them many times over an AFO. Um, and they're willing to wear them day to day because they're relatively comfortable. The problem is, in the United States at least, most third-party payers and certainly Medicare will not cover this treatment, as the well-known excuse is that it's experimental, even though these treatments have been around almost 30 years and have been proven to be effective. So if anything, the patients that they seem to be using the most on are multiple sclerosis patients, as well as patients who have had trauma to the common peroneal or have conditions proximal to the common peroneal nerve. If the common peroneal nerve itself is damaged, it doesn't do any good to stimulate it. You'd have to stimulate it much more distally. So this is for a more proximal origin of a foot drop, most notably in multiple sclerosis or in stroke patients. And so patients should be given this option to consider. These devices cost anywhere from $5,000 to $7,000, but there are patients willing to pay for this out of pocket, and it's something that should be considered for all patients who qualify. Ankle foot orthoses, we're going to talk about in a minute, and we're going to briefly review other surgical treatments. We already talked about decompression procedures of the common peroneal nerve. Certainly patients who have refractory foot drop and have failed conservative treatment and who really, for some reason or another, do not want to or cannot wear ankle foot orthoses, the option of dynamic tendon transfer should be discussed with the patient. If they have a compression neuropathy of the common peroneal nerve, obviously that decompression surgery would be preferred over tendon transfer. There are patients who have common peroneal nerve injury or sciatic nerve injury in an area greater than 6 to 12 centimeters who are not candidates for nerve reconstruction or nerve grafting, who may actually be considered for tendon transfer. Patients who have global polyneuropathy, such as Charcot-Marie tooth, are not necessarily good candidates for tendon transfer because the disease is progressive and it eventually involves multiple tendons and muscles in the lower extremity. When we look at tendon transfers, we obviously have to go back and look at where the nerve injury originated from and look at what muscle groups are affected. And these patients must undergo a nerve conduction study and EMG to determine which muscles have been left intact and are not affected by disease or injury. And when we look at the causes of foot drop, which I've just spent a half hour going over, we realize there may be a limited number of patients who are candidates for a tendon transfer because they have to have an intact tibial nerve, intact posterior tibial tendon muscle group, and in some cases, intact peroneal muscle group without progressive muscle disease or systemic disability. So notwithstanding, tendon transfers are commonly performed. The most common is the tibialis posterior muscle tendon group transferred through the intermuscular septum and attached to the intermediate or middle cuneiform. And that is done successfully in cases where there is a healthy, functioning posterior tibial muscle group with an isolated foot drop and or peroneal muscle injury itself. When the peroneal muscles are lost, sometimes a combination tendon transfer involving both the tibialis anterior and the tendon of the peroneus longus or brevis are anastomosed to the transferred tibialis posterior tendon. This gives kind of a sling effect to both the medial and lateral aspect of the foot, along with the activation of the posterior tibial tendon. So when the posterior tibial tendon fires, it not only dorsiflexes the foot, but with proper balancing of this anastomosis, we can prevent the varus rotation of the foot and ankle when the peroneal musculature is lost, and balance out as well as the tibialis anterior. So the bridle procedure was developed 30 or 40 years ago and is still commonly used as a tritendon anastomosis for foot drop. I want to point out that these patients, when the tibialis posterior is transferred, must undergo rehabilitation and gait training because the tibialis posterior muscle is not activated during the swing phase of gait. The tibialis posterior muscle in healthy individuals doesn't fire until heel strike, and therefore it doesn't really activate and prevent foot drop after a tendon transfer unless the patients undergo gait training with a physical therapist who literally teaches them to invert their foot during swing phase, which activates the tibialis posterior earlier during the swing phase of gait up in here, and therefore will prevent foot drop during swing phase. And it's remarkable, these patients can be trained, and the tibialis posterior can become an extensor of the ankle during swing phase, and the satisfaction rates with that surgery is actually quite high. What's interesting, something that I've been lecturing on for 30 years, is the fact that these patients who undergo transfer of the tibialis posterior tendon don't develop a flat foot deformity. We've always attributed adult acquired flat foot to rupture of the posterior tibial tendon. But when we take patients who have foot drop and purposely detach the posterior tibial tendon and move it to the dorsum of the foot, these patients don't develop adult acquired flat foot. And the reason is they have an inactive peroneal musculature. And this has been pointed out in 2 or 3 studies, the first of which was published over 20 years ago in 2001 by Yeep. And he looked at a series of 17 patients who he performed the bridle procedure on for foot drop. And he noted that none of them developed a flat foot afterward. Well, the reason is they had totally inactive peroneal musculature, which if they were intact in the peroneal muscles, they most likely would have developed a foot drop. We know that rupturing your posterior tibial tendon then allows the peroneals to set up a cascade of events that leads to adult acquired flat foot. But when patients have a common peroneal nerve injury or palsy that affects the peroneals as well as the dorsiflexors, They don't get a flat foot deformity when we transfer the posteriotibial tendon. So I guess that's one good part of having the combination of a deep peroneal and a common peroneal nerve palsy. Okay, and finally, for our purposes, we're going to go through drop foot bracing. And the ideal brace for drop foot or the goal is to provide dorsiflexion during the swing phase of gait. Ideally, we allow plantar flexion range of motion throughout the stance phase of gait. We want the device to fit comfortably in all types of footwear. And in many of these patients, we want the device to be cosmetically acceptable. So we want to prevent this passive foot drop during the swing phase of gait so that the toes can clear the ground. And when we pick the brace for the patient, we have to really look proximally. We have to watch these patients walk, and we have to look at a number of key clinical findings in order to pick the proper brace. So we use this chart, which is in the Richie Brace website, and this may look confusing to you, and I'm going to go through this briefly, and in the end, I'm going to tell anyone who's confused by this, feel free to reach out to me. I'm available 5 days a week by email via the Richie Brace website. We have a consultation page. It allows you to email me and show me a patient video or any other clinical information, and I will respond by email or telephone call, and I'll help you pick the right brace for your patient. So the first thing we want to look at, most importantly, is whether their knee is stable, because a lot of patients with foot drop have instability of the knee because they have proximal muscle weakness or other comorbidities leading to joint contracture. So some of the Richie braces can control the knee and some Richie braces won't. And in many cases, we tell you to refer the patient out to a qualified orthotist who offers other braces that can stabilize the knee or even the hip. So I'm going to just show you some key things to look for in your gait analysis. So it's interesting that the knee is many times stabilized by the ankle, and the muscles that stabilize the ankle in a secondary way stabilize the knee. And so when we walk and the tibia migrates over the foot, the soleus is what prevents anterior migration of the tibia and fibula over the foot during mid-stance. If the soleus is not controlling the tibia, the knee will buckle. The knee will go into a flexion deformity. And so a leg muscle stabilizes the knee indirectly by stabilizing the ankle. So with soleus muscle weakness, you will see the knee go into hyperflexion. The knee will go into flexion too with hamstring tightness, but sometimes we'll see this child walking with a flexion deformity at the knee. It's because their soleus is weak. Or it can be in an adult patient who has rupture of the tendo Achilles. They will often go into a knee flexion because the soleus has lost power. A great AFO solution for posterior weakness and flexion of the knee is an anterior strut AFO, a carbon fiber AFO. We used to offer one of these. We've temporarily suspended it because our factory in China closed down, but these are available through multiple other websites and vendors. Rather than go into flexion, the knee can go into hyperextension, and we see this commonly with severe equinus deformity at the ankle. We will see this in polio patients. We'll see it in children with severe equinus. In many cases, it requires a solid AFO to push the tibia forward and prevent the recurvatum deformity at the knee. So this is a polio patient demonstrating that classic equinus deformity, foot drop, and significant recurvatum of the knee. And that recurvatum really is best treated with a full-length solid AFO or even a knee ankle or so-called KFO, knee ankle foot orthotic system. We make a solid AFO with a podiatric foot plate. This is a very nice AFO for cases like that where we're trying to stabilize the knee and stabilize the tibia. And it has a place for some patients with foot drop. Our preferred brace for foot drop, though, is the dynamic assist brace. This is indicated for those patients who do have a stable knee and they do have adequate ankle joint dorsiflexion to achieve at least 90-degree positioning. They also cannot have severe or noticeable spasticity of the posterior leg musculature. Now, happily, this brace can work on a lot of patients, such as stroke patients, patients with common peroneal nerve entrapment, and as I showed you, some patients with Charcot-Marie tooth. This brace is reimbursed nicely by Medicare because you can bill not only for the brace, but you can bill for the tamarack hinges that are applied both medially and laterally. The total reimbursement on this brace is well over $1,200. The brace works in a very simple way. It has these spring-like hinges, which are the brace is applied to the ankle in a dorsiflex position. Once the brace is tightened down with a posterior strap and the patient stands upright, there's tension applied to the springs. And the minute the patient lifts the foot off the ground, the brace pulls the foot into dorsiflexion passively during the swing phase of gait. Very simple mechanism and very effective. The nice part of the brace is it fits nicely into most lace-up shoes, and it's a low-profile brace that doesn't have to go all the way up the leg. For those patients who have some posterior contracture and spasticity and also have equinus, they can't wear the dynamic assist brace. And in this case, we recommend our restricted hinge pivot brace. And I'll give you some examples of where to use that. So when we compare the restricted hinge brace to a solid AFO, the solid AFO is much more effective in stabilizing the knee, but it also restricts the ankle joint quite a bit, and there's some compensatory mechanisms. So we would certainly prefer our restricted hinge brace, but they need to have a stable knee. If we compare the restricted hinge to the dynamic assist, we need a stable knee for both patients, but it's really equinus that differentiates. We cannot use the dynamic assist brace when patients have equinus contracture. So in cases of spasticity of the posterior calf, in most cases, we recommend you refer these patients out. The older fashioned braces that were used for these had what was called a plantar flexion stop mechanism to prevent the ankle from going into equinus contracture. But nowadays there's, well, here's a video of a patient with cerebral palsy. And these patients, oh, wow, it didn't have the video. Well, anyway, cerebral palsy patients are classic cases of those with contracture, spasticity that would benefit more from these sophisticated newer braces that have controlled ankle joint motion mechanisms that are actually quite remarkable. One of our Richie brace distributors, Becker Orthopedic, developed this this so-called triple action joint right here that can be calibrated to control contracture and still allow motion, depending on the level of stability of the knee and even the hip. Very sophisticated joint that is best handled by someone who's trained with this kind of methodology. And just to let you know, it's out there, and certainly one that we recommend when there's significant proximal instability of the knee and hip, as well as joint contracture and spasticity. So these braces have these very remarkable adjustable joints at the ankle to control the tibia and the hip and the knee. But the more common patient that presents to the podiatric physician, like this one I showed you earlier, who's had a mild stroke, a mild foot drop, but it bothers her because she trips and falls when she's tired. She doesn't like wearing a traditional solid AFO. She likes wearing her Skechers tennis shoes. We fitted her for the dynamic assist brace because she does not have contracture spasticity, and this brace allows a heel strike. And she's happy. It allows her to clear the ground during swing phase, allows her to heel strike, and it fits nicely into her Skechers athletic shoes. This is a patient who was 29 years old and suffered a stroke. And she didn't know it, but she had lupus. And she had joint pain, but never went to the doctor. Turns out lupus has a subcategory of patients who get hypercoagulability, and they can suffer an ischemic stroke. And this patient, if we watch her walk, has left-sided hemiplegia, 29 years old. So she's got a mild foot drop. She too likes wearing Skechers tennis shoes, doesn't like wearing a solid AFO. She does not have significant joint contracture, and she's a mom. So we fitted her, perfect candidate for the dynamic assist brace. It fits into her Skechers shoes, and it allows her to heel strike, and it's not a large, bulky AFO. And she's very happy with the results of that treatment. This is a patient with a common peroneal nerve injury from abnormal posturing during sleep. He injured his common peroneal nerve by habitually sleeping on his right side. And he's otherwise healthy and active. He plays tennis 3 times a week, but he can't because he's developed this right-sided foot drop. Not a lot of varus instability and no contracture. So he was a good candidate for the dynamic assist brace. And he's very happy because he can play tennis with this brace. He heel strikes and shows good stability throughout the stance phase of gait. So this is a very gratifying outcome. So this is I'm going to skip through this. And so this one's one of my more interesting stories. This gentleman is in his 60s, and he walked the Camino walk in northern Spain, which is over 400 miles, with a drop foot. And he did it with our dynamic assist brace. And this is what his shoes and the brace look like after he walked 450 miles. And he came in because the brace was worn out. The hinges had lost their spring, which they do after about a year of normal use. And in his case, it was after walking the Camino, which is essentially the entire distance of northern Spain, beginning in France and ending up on the Atlantic Ocean on the west coast of Spain. And here he is on the walk. He walked about, anywhere between 15 and 25 miles a day. And there he is with his dynamic assist brace on. And his injury was interesting. He was an avid mountain biker and had a contusion injury and laceration to his anterior tibial musculature and led to a compartment syndrome. He had to have a fasciotomy done to his anterior muscle group. And it left him with significant weakness of the anterior tibial musculature. This was not really a nerve injury as much as it was an anterior muscle injury to the left lower leg. Relatively mild foot drop, but definitely impairs him for long distance hiking, which is what he likes to do. So we fitted him for the dynamic assist, and here he is walking with a much more normal gait pattern, and he's heel striking, which is really what he wants to do, and he walks 400 miles. So finally, Jalon Smith with the common peroneal nerve injury. And I just wanted to show you anybody who has an athletic patient who might be reluctant to wear, for example, the dynamic assist brace for fear that it would inhibit performance. Um, Here's a picture of Jalon Smith working out with his dynamic assist brace on with a foot drop. And you would never know that he's wearing a drop foot brace or even has a drop foot. So if anyone says he thinks that dynamic assist brace would inhibit athletic performance, I'll be happy to send you a video of Jalon Smith wearing our brace. So with that, I've kind of gone overboard, and so I'm going to open this up for questions. Before I do, I just want to point out that all of our Richie braces are offered by a unique group of 12 authorized distributors. These are companies that also offer foot orthotics and other types of AFOs. They are trusted Richie brace distributors who have been well schooled and trained in providing client service to you regarding ordering, pricing, shipping of all of the Richie brace products. And they are listed on the Richie brace website under our distributor side. And they can answer most of your questions. But if they can't, I can answer them anytime you want by going to the consultation page on our website and reaching out directly to me. So with that, I'm going to stop screen sharing
And
and ask
I am
Sarah.
here. Yes, I am here, Dr. Richie. I am just going to keep myself hidden though, because every time I go back and edit these videos, it is a pain in the butt when my face is on there. So,
Okay, that's no problem.
yeah. Okay. So we actually finally we have one question that just came through. So could an and oh my gosh, of course it's gonna challenge me here with this word ischemic. Could an ischemic stroke occur in the spinal column that might cause a foot drop?
Yes, and I should have mentioned that, but ischemia and uh, thromboembolism events at certain levels of the spinal cord, particularly higher up in the lumbosacral plexus, can lead to foot drop. And so these patients sometimes aren't aware of it. You know, a stroke is a major medical event where patients lose consciousness usually and they're rushed to the hospital. But patients can have ischemic events that compromise the spinal cord and they're not aware of it. So you may be the first person to pick up on it with gait analysis.
So I have a question. Did you use the word insidious a bunch because we're coming up on Halloween?
No, Freudian slip.
Okay, gotcha. I just wanted to make sure. Well, I'm going to give everybody a couple more minutes here to ask questions, but that's our only question. You must have just done the most brilliant job ever of covering everything. Oh, and we
Okay.
got one. Okay. And we will wrap this up pretty quickly just because it is getting late. So if you do have a question, this is the time to get it in. Could you please elaborate on your experience with drop foot in patients with TBI injuries? I think it's TBI, and unless that's an L. I think it's TBI.
Yeah, I'm not sure what TBI stands for. Ask them to
Would it be TBL? Would that make sense?
TBL total.
Oh, here we go. Traumatic. Oh, okay. Traumatic brain injury.
Oh, yeah. Yeah, I didn't really list that in there. And, you know, I saw a number of patients over my career with who had suffered unfortunate traumatic brain injury. And I learned a lot about it. And I was successful treating a lot of them, and I was unsuccessful. But luckily, I have some great orthotists I work with. The problem with traumatic brain injury is it combines all of the challenging elements that I listed under my contraindications for Richie braces. Um, First of all, the global effects of it on multiple muscle groups, not just in the lower extremity, but upper extremity. Number two, almost always spasticity and joint contracture. And the presence of that spasticity really requires such really careful evaluation of gait and selecting the proper AFO that can control spasticity. And finally, the monitoring of those patients during their recovery, because happily and in a very gratifying way, many of them recover to some degree and require constant modification of their AFO device and replacement to different types of hinges and ankle joints, etc. So while the Ritchie brace can be useful for some patients with traumatic brain injury, the presence of contracture and spasticity would certainly warrant the podiatric physician to be really mindful during the gait analysis, et cetera, and perhaps reaching out to me to really look at those patients and see if any of our braces are really relevant.
All right. Says, could you please send the link for watching this presentation? Yes, I will do that. So this is being recorded, and we should be able to get this up on the website by tomorrow. So keep your eyes peeled for that. And obviously, we'd love for you to share with your colleagues as well for anyone who wasn't able to join us live this evening. But we're gonna go ahead and wrap that up, I think, because we just we don't, everyone must be sleepy. So, but we do have a lot of people online tonight, and we still have a lot of people that are still here till the very end. So thank you so much for sticking with us this evening for tonight's presentation. Obviously, an extremely informative presentation. So again, keep your eyes peeled for that recording, and don't hesitate to see the list of authorized distributors at richiebrace.com, and then keep in mind Dr. Richie's note about visiting the contact us page. There is a consultation form there on that web page that I will see, and then I and Dr. Richie, so we have just little checks and balances, so we make sure that none of your questions go unanswered. And obviously, feel free to answer or to ask any and all questions, within reason on that webpage. But otherwise, Dr. Richie, home run. I didn't mean to say that because even though we're coming up on the World Series, but it works. So,
Well, I will say go Dodgers, but that was very applicable. So
yeah,
yes,
right.
home runs are very helpful right now.
Absolutely, wherever you can get them. So we'll keep everybody posted too on Dr. Richie's next live webinar. We usually do these about every 3 months. So I just hope everyone keeps showing up, and I appreciate the time. And Dr. Richie, thank you so much. This has been awesome.
Thank you. Good night, everybody.
Good night.